So we will start without any further ado. Today, inshallah, we will be going through a summary of the lectures that you have studied in a didactic, short didactic summary. Also, we'll have case presentations and small pop quiz or picture session where you can identify different lesions and conditions. And then finally, we will have a discussion. You can ask questions if you will, and you can comment on the information that we have shared. So we will start immediately with the summary. So the epithelial pathology chapter discussed several conditions related to the epithelial tissue that can be encountered in the or in the close vicinity of the oral cavity. The conditions ranged between reactive lesions that are stimulated by specific or a variety of stimuli, such as viruses, bacteria, fungi, in addition to trauma or exposure to certain elements in the environment. Examples of this condition include inflammatory papillary hyperplasia due to chronic trauma or irritation combined with low-grade fungal infection. We also Hex disease due to viral infections and some other conditions in this category. Also, among the conditions we discussed were the different types of tumor or abnormal growths originating from the epithelium, starting with benign epithelial tumors such as squamous papilloma and keratoacanthoma. Covering after that the pre-malignant conditions and lesions such as leukoplakia, erythroplakia, actinic cheilitis, among other conditions, as well as some lesions, erythroplakia and leukoplakia and actinic cheilitis are actually lesions. We also looked at some conditions, for example, oral submucous fibrosis. In the final lecture, we covered examples of the malignant epithelial tumors that can affect the oral and paraoral region. Going through hallmarks of malignancy was a focal point of the lecture. So we looked at all the features that can separate or discriminate different types of cancer from the normal tissues in the body. And then we focused on examples from the oral region. We discussed the most common epithelial oral tumor, which is oral squamous cell carcinoma, which represents by a vast majority, more than 90% of the cases in oral tumors. We also covered a couple of other examples of malignant epithelial tumors, for example, basal cell carcinoma and verrucous carcinoma. So now this is the time to start testing the knowledge that we have shared in the lectures by looking at some cases. I will read the cases, I'll show you a picture or two, and then I'll give you the chance to think about it and write your answers in the comment area, or in the chat area if you have an answer for the questions that we have. So starting with, excuse me, I did something wrong here. Yes. So the first case, we have a 46-year-old male, which was presented with a lesion on the right buccal mucosa from the linea alba through the buccal vestibule to the area of the tooth number 30 and tooth number 31. So the buccal mucosa appeared white and wrinkled. The patient has an extensive history of tobacco and alcohol use. He has been using tobacco for 20 years and drinks different types of alcohol. The lesion has remained relatively unchanged until the patient changed the location of the dipping. Then he developed a similar lesion on the left buccal mucosa, and this is the new location where he started dipping the tobacco. The patient has hypertension, but there are no other significant health issues. The histology of the lesion showed the surface covered with a thick orthokeratin and perakeratin. The spinous layer shows focal thickening, mild and focal hyperchromatism is also noticed, as well as some nuclear crowding. I will show the pictures of both the clinical presentation and the histological presentation. So in picture A, you can see this is the clinical presentation of the case at the time of the examination, the first time of examination. And in B, this shows the improvement of the lesion after the patient ceases to dip the tobacco on this side. And in C, you can see the new formed lesion appearing on the left side since the patient started dipping tobacco there instead. In the histological picture, you can see abundance of keratin. I want you to notice that some of the keratin shows nuclei, and this is the parakeratinization, and some of it doesn't show nuclei, and this is the orthokeratinization. So you actually have a mixture of the two. I can point to them here. This is the parakeratinization, and this is the area of orthokeratinization. So the difference between the ortho is that we don't see nuclei in the keratin layer, and the parakeratinization, it shows nuclei. So you can see both of them. If we look at the spinous layer or the brachial cell layer, you can see that it's quite thick. And if you look at the basal cell layer here, you will notice a little bit of hyperchromatism or dark coloration of the nuclei, as well as some crowding at the base. So now I want you to think a little bit about this and come up with I want you to give me the name of the lesion that you can see. I want you to tell me the different types of the condition that you can see and which one is the most serious in your opinion. You will have some minutes to think about it.
Feel free to post your answers in the chat box below, or you can raise your hand and use the microphone.
I can go back so you can look at the pictures again if you want. Okay, anyone? All right, we can move on. So we can see the name of the lesion. This is leukoplakia. Why did we say it's leukoplakia? It's because of the appearance, the clinical appearance and the histological appearance of the lesion. So the clinical appearance, it says in the description that is white and wrinkled. It's found in the area of tobacco dipping. So it's most probably caused by tobacco dipping. You can call it tobacco-caused leukoplakia. It did not mention that in the description, but it was not, the patient is not, or the dentist was not able to wipe it off in the clinic. So now I want you to think about the types, different types of leukoplakia. that are covered in the lecture, if you can mention them, and which one exactly is the most serious that raises the most red flags for the dentist or the treating doctor. All right, we'll give it 2 minutes and then we will reveal the types of leukoplakia. Okay. So we have 4 types of leukoplakia. We have thin leukoplakia, thick leukoplakia, nodular, and verruciform. These 4 types, the most serious type is the nodular and verruciform, mainly because they're highly irreversible, so usually they do not go back. Also the thick to some extent, but it's not as serious as nodular and verruciform. The thin type, which is the case of this patient, it have a chance of reversing back to normal, as we saw in the description of the case. When the patient stopped dipping tobacco in the area, the mucosa improved and it started appearing on the other side in the new location of tobacco dipping. So this gives away the type here is thin, even though it has some features that are a little bit worrying, like the crowding and hyperchromatism and the acanthosis or thickness of the spinous cell layer, which all direct us or indicates the direction that this lesion can go to in case of continuous tobacco use and alcohol use. And if the conditions are perfect, it might progress to thick, or it might progress to other forms of leukoplakia or even into malignancy. So this is quite early detection of this case, and it would be best for the patient if they stopped tobacco dipping and moved and allowed the epithelium in this area or the mucosa to heal and to go back to normal. Okay, so now we move to case number 2. So this case here is for a 44-year-old white male with numerous pink white papillary lesions, some of which are exophytic, so they grow to outwards, and many of which are flat and spongy in nature. Lesions are found on the lips, bilateral buccal mucosa, the vestibule, the tongue, and the floor of the mouth. So it covers quite a lot of the oral cavity, except maybe the palate. Every other area in the oral cavity has or contains some of these lesions, multiple lesions. The lesions are of over 2 years duration, so the patient has them for quite a while. But there are little symptoms except occasional trauma when the patient catches the lesions between his teeth while he's eating. Otherwise, they are asymptomatic. The patient has similar lesions in the perianal area, and the past medical history includes multi-drug resistant HIV and previous poor compliance with HAART, which stands for highly active antiretroviral therapy. There is recurrent bronchial and pulmonary infections. He also has a history of heavy cigarette smoking, which he stopped recently. Now I show you the picture of these lesions, the clinical presentation. You can see that the patient has multiple lesions covering the lips, the buccal mucosa. We can't see it here, but it's the floor of the mouth and the tongue as well, and extends back to the edge or the periphery of the palate, in fact. Maybe the palate is also included. So you can see the nature of the lesions. Some of them are exophytic, as you can hear, and some of them are quite flat and they don't have a neck. They are flat and smooth on surface, and some of them are exophytic and rough on the surface. So the lesions were taken out for histological examination, and the histological examination showed this picture. So here we have an H&E stained lesion with zoomed out, so you can see it under small magnification. It shows papillary epithelium covered with parakeratin, supported by a fibrous connective tissue core, which you can see with the light color in the middle of the lesion here. And the spinous layer contains, you can't see it here, but it contains coilocytes. Coilocytes, it refers to virally infected cells. And to find out the type of the virus that we're dealing here with, there is a special stain here. Immunohistochemistry was used, and the scientist or the doctor used human papillomavirus antibody, and it tested highly positive, strong positive result for subtype 6 and 11 and 16, which is demonstrated here by the dark staining of the nuclei. And these nuclei are found in the surface area or the spinous cell layer of this lesion. So they cut this small part here and enlarged the photo so you can see these nuclei. They are darkly stained. So now the question is, what is the differential diagnosis of this condition, and what is the final diagnosis eventually? You can think about it for a couple of minutes and then we can start discussing it. Yeah, we have an answer here. Squamous papilloma is very good. Nodular type of oral leukoplakia. Yep. Okay, we can talk about it a little bit later. It's very good. Okay, any more? Any more suggestions? All right, then. Let's look at the differential diagnosis together. So the differential diagnosis here include multiple lesions of squamous papilloma, oral squamous cell carcinoma, condyloma acuminatum, verruciform xanthoma. Why did we mention all these lesions? In squamous papilloma, it contains virus, human papilloma virus, but it usually is only accompanied by type 11. We have seen in this case, we have type 11, type 6, and type 16. So this puts it in the top of the differential diagnosis list. Also, squamous papilloma is usually a solitary lesion, so it's not seen as multiple lesions, except in very rare cases. Among these cases is HIV infection. from the description of the case, this patient is HIV positive, actually has a resistant to HIV antiviral treatment. So this gives us a little bit more motivation to believe or to expect that multiple squamous papilloma might actually occur for this patient. However, squamous papilloma does not appear in the anogenital area because this patient has these lesions in the oral cavity and in the anogenital area as well. So this makes it a little bit suspicious, or we may have some doubts. If we talk about oral squamous cell carcinoma, well, oral squamous cell carcinoma can show exophytic growth, and it can show different type of clinical presentation. It does not have a unique picture, so this makes it also one of the expected conditions. However, it is not seen as multiple lesions all over in the same time. This is not a very usual picture. As well as in the histology, we did not notice any invasion for the lesion into the connective tissue. So one of the very well-known features of oral squamous cell carcinoma is the invasion in the surrounding tissues, which is not seen here. Condyloma acuminatum is a condition that is caused by human papillomavirus. It is actually seen in the oral cavity and in the genital area as well. It's accompanied by 11 and 6 human papillomavirus subtypes. It is usually seen in patient of younger age. So this patient is 40, in his 40s. It is not the typical group of patient that we can see them, but it is, I mean, biology is not typical. So this is also a very valid differential diagnosis. Verruciform xanthoma is another condition that has very similar clinical presentation with exophytic growth of lesions. However, it is not caused by human papillomavirus, which is strongly positive. The nuclei are strongly positive for human papillomavirus, which somehow pushes verruciform xanthoma to the bottom of the list. So given all these factors, what do you think is the final diagnosis? Looking at these 4 differential diagnoses, I want you to give me a suggestion for the definitive diagnosis of this condition. Okay, multiple squamous papilloma. Any other suggestions? Condyloma acuminatum. All right. We will not delay it anymore. It is, in fact, condyloma acuminatum. The reason for that is the presence of oral lesions and anogenital lesions. So this is condyloma acuminatum, but it can pass, it has so many features similar to squamous papilloma, so it can, I understand why would you think that, but you have to focus on the fact that this patient has these lesions both in the oral cavity and in the anal area, so this will exclude the squamous papilloma. Moving on to case number 3. How do we differentiate condyloma acuminatum and Hicks disease? Let's just hold this thought and we can discuss it later on in the discussion time, if you don't mind. So this third case, this is a 65-year-old white male who is presented with a single deep ulcer on the right lateral border of the tongue. The lesion measures 1.5 by 1.5 centimeters in diameter, lasting for several months. History of chronic cigarette smoking for 50 years. The lesion is asymptomatic unless accidentally traumatized while chewing food. Examination revealed well-demarcated but heavily keratotic lesion as manifested by the rough white surface. There was no cervical lymphadenopathy. Incisional biopsy was performed and histological examination reveals 2 pieces of soft tissues exhibiting epithelial neoplastic changes, invasion of the underlying fibrous connective tissue. Individual cell keratinization and keratin pearls are also present in the histological picture. I will show you both pictures, the clinical and the histological picture. This is the photograph that was taken at first clinical presentation when the patient came to the clinic first time. I want you to note the large keratotic single ulcer on the mid-lateral border of the tongue. And you can see it here. And take your time, look at this. You will also see here, this is the histological pictures. Look at the neoplastic epithelium seen in this area. And it is invading the skeletal muscle bundles of the tongue. We can see keratin pearls in the middle of these invasion areas. This is keratin, which is an atypical location for the keratin, which is usually found on the surface rather than the center of an invasion island. So I want you to tell me, what is the differential diagnosis of this picture that you see, and what is the final diagnosis after you think about it, of course, for a couple of minutes. Squamous cell carcinoma is the first suggestion. I'm looking for a differential diagnosis, which is usually 2 or 3 conditions. Well-differentiated squamous cell carcinoma. Okay. Let's try to find differential diagnosis also. Syphilitic ulcer. Yeah, okay. This depends also on the history, the medical history of the patient. It did not, in fact, mention anything about the patient having syphilis, but it is a reasonable suggestion. Okay. Let's look at some differential diagnoses. So traumatic ulcer. The location is a very highly exposed area of the tongue that might be traumatized by chewing, by a sharp edge of tooth, or some similar conditions. So traumatic ulcer is the first differential diagnosis. Keratoacanthoma is another type of tumor that is expected here, because keratoacanthoma usually shows very highly keratotic center. We see some keratinization here. Squamous cell carcinoma of the tongue is another differential diagnosis. So usually when we look at the tongue, trauma is a very important factor that we should consider always. But because the patient said that this is present for several months, the trauma is not usually, the tongue will, if it's only trauma, it will heal eventually. Since this one did not heal for several months, this is very suspicious. Keratoacanthoma is a condition that is definitely very similar to oral squamous cell carcinoma. And we talked when we discussed it in the lecture that we have to be very careful of not misdiagnosing keratoacanthoma with oral squamous cell carcinoma. The thing is, the location does not fit. So keratoacanthoma is usually found on the skin, so the vermilion border of the lip is the most expected location if this is keratoacanthoma, which will lead us to squamous cell carcinoma of the tongue, a well-differentiated type, which is definitely our final diagnosis here, as you mentioned. And the reason is squamous cell carcinoma takes months to grow. The patient, it does not take months to grow, it takes years actually to grow, but it appears as a non-healing ulcer, which is the case for this patient. The ulcer has been there for several months without healing or without causing any pain. It has a base that is hard due to keratinization, rolled over edges, very typical for oral squamous cell carcinoma presentation. And the striking feature that should leave no doubt is the presence.
ده جابوا فعلا يوم الأربعاء بخلي لك الدروس تمام ولا شوي تجيبه.
Yes, so the striking feature that should leave no doubt is the presence of invading islands, which is a group of epithelial cells found in the middle of the tongue muscles. This is not a usual picture by any means. And also the presence of keratinization, not on the surface, but in the middle of the lesion, which is a feature of well-differentiated tumors. So these have been our cases for the day. Now we will move on to some questions about appearance of some lesions. So I will show you a picture of a lesion. I'll give you a minute to think about it, and then we can, and you can give your suggestions in the chat, or if you want to unmute yourself and say it in the microphone, you can do that too. And we have some conditions from the group we covered in the lectures. So now I want you to look at this, identify the condition and the location and the significance of the lesion. This is the lesion, if you're wondering. This is the lesion. Okay. So smokeless tobacco keratosis. Let's see if this is actually correct. This is hyperkeratosis. Yes, can call it leukoplakia. The location is lower lip. And the significance of the lesion is that it's a pre-malignant lesion. It's one of the pre-malignant lesions. Why? Because the continuous use of tobacco in this area might lead to some transformations in the cells. This transformation would start with hyperkeratosis or leukoplakia that might start as thin and then continue to become thick or nodular, and might also be transformed into oral squamous cell carcinoma. Oral submucous fibrosis of the lower lip is, it does not contain, in some cases, and the white color is not because of the keratin, but it's because of the fibrosis that is found in the submucous area. So there was no, we can't tell just by looking at this, and usually oral submucous fibrosis is a condition, so it does not only affect the lower lip, it will rather affect the entire oral area or the oral cavity. So yes, it is smokeless tobacco hyperkeratosis. Yes, excuse me. Does anyone has something to say?
No, I think you can go ahead.
Yes.
Thank you.
Okay, so thanks, doctor. So it is a potentially, it's not a potentially malignant lesion per se, but it is a pre-malignant lesion. So yeah, well, we can say potentially malignant, but then it is not 100% guaranteed that it will be malignant, but it is, a high risk condition. Okay, the next one. I want you again to identify the condition, the location, and the significance. I think this is really easy. Would you agree? Okay, we will have 30 seconds just because we are pressed on time. In 30 seconds, we will move on. Anyone? Okay, oral leukoplakia of the floor of the mouth. It's a pre-malignant lesion. Thank you very much to those who answered. It is, in fact, leukoplakia of the floor of the mouth. And this is not due to dipping of tobacco because the location is not typical. It is actually an idiopathic leukoplakia, so it has not a well-known reason. It's just, it occurs spontaneously, which is the significance of the idiopathic leukoplakia is that it has a very high risk of pre-malignant, of malignant transformation, even higher risk than the tobacco dipping, because in the tobacco dipping, we know the immediate reason or the stimulus and you can stop it and hope for improvement of the condition. But when we have idiopathic leukoplakia, we don't have the reason for it. Even if we remove it, it might come back. So it has a higher risk of malignant transformation. Moving on. This condition, I want you to identify the condition and the significance of the location. Why is the location special? Denture stomatitis. Okay. It seems like there is a consensus. For denture stomatitis, okay. Well, you can also call it papillary hyperplasia. Papillary hyperplasia of the palate. It is actually due to ill-fitting denture, but it is usually accompanied by fungal infection or candida infection, low-grade type. So the location signifies the importance of the location is that it actually gives away the cause for the condition. Because of the denture wearing patients, when they have ill-fitting dentures, this will lead to accumulation of food or chronic trauma in this area, leading to this infection, which will eventually appears clinically as the aggregated little papillary red projections in the hard palate. We talked about the treatment of this condition, and we said just remove the denture, try to fix it if you can do that with liners, and provide some relief for the palate, treat the fungal infection by antifungal treatment, and advise the patient or educate the patient about the care for the denture. And if it's not possible to fix it, you can just reconstruct it. Depends on the condition and the situation of the patient. I want you to identify the condition and notice the location. What is the importance of the lesion if you look at the location here? Okay, any takers? Latent form of HSV1. Okay. It could be a differential diagnosis. Anyone else? I want you to think about the conditions we covered when we covered epithelial pathology. Basal cell carcinoma, yes, it's a very, very likely diagnosis, but let's just reveal it. This is keratoacanthoma. So keratoacanthoma is a benign epithelial tumor that occur in the vermilion border of the tongue. And it has a striking similarity to oral squamous cell carcinoma, which makes it very a sensitive condition you have to take care of the whole diagnosis situation here. It also may be confused with basal cell carcinoma, like Selma here said, because basal cell carcinoma occur more or less in the same area. But I want you to notice that this lesion lacks the pearly appearance of basal cell carcinoma, the pearly appearance and the telangiectasia, or the small blood vessels crossing over the surface of the lesion. So this looks like a keratinized lesion on the edges, and it has a so it's like concentric circular shapes that is seen, which is more compatible with keratoacanthoma. Yes, so another condition that has lesions that are found on the lip in this case, can you identify it? And can you identify the cause? Okay. Any suggestions? Squamous papilloma, HSV. Yeah. Okay. Let's reveal it so we don't string people around. Okay, this is focal epithelial hyperplasia or Hicks disease. Yes, it is actually caused by human papillomavirus, subtype 13 and 32. So this is a condition that is, you asked the question before about the difference between Hicks disease and condyloma acuminatum, and there you have it. The first difference between the two conditions is that the subtype of human papillomavirus is different. So 6 and 11 are for condyloma acuminatum, 13 and 32 are for human, for focal epithelial hyperplasia. Also, the genetic predisposition is very highly seen in ethnic groups, in the Americans and Native Americans or Native Indian Americans. And the age group is different. Focal epithelial hyperplasia is seen in young children and in teenagers, while the condyloma acuminatum is seen in, also in a young group, but not in children, except in very specific conditions or situations, such as victims of sexual abuse, because it's transferred from the from one person to the other through sexual contact, while focal epithelial hyperplasia is not like that. Also, acuminatum condyloma can be seen in the genital area, while focal epithelial hyperplasia does not. So these are the differences between the two of them. Moving on. Can you identify the condition, and can you appoint the most common cause of this condition? You are welcome. No problem. Verrucous carcinoma. Thank you very much. It is verrucous carcinoma. It's very, very typical. The appearance is quite typical. It's not very confusing. So, yeah, the cause, verrucous carcinoma, the most common cause of verrucous carcinoma is tobacco dipping. And this is actually caused by tobacco dipping. Notice the appearance, the cauliflower, very rough exophytic appearance. It's located in the alveolar ridge of the upper jaw. As you can see here, the palate, you can see here the tooth, I think is the canine. And this is one of the molar teeth. So this whole area, I would expect the patient to dips the tobacco in this area here. So this area is transformed into this very special appearance. Following one. I'm sorry, Dr. Safa, I think we already at 5 o'clock, so I don't know if this is a problem. Should I stop the presentation here? Just go on, continue with it.
No, it's okay. You can go on. It's okay.
Okay, thanks. So looking at this lesion here. This lesion here. Can you give me a suggestion? The location? Yes, this is the ventral part of the tongue, partly also the floor of the mouth, you can say that. So it's the lesion starts at the floor of the mouth and continues to the base of the tongue. But what is the condition? Definitely, this is squamous cell carcinoma of the floor of the mouth. So you can notice that throughout this presentation, we have seen a couple of cases of oral squamous cell carcinoma, and each and every one of them looks a bit different from the other, which makes it tricky. Yeah, it has many different presentations. You just have to pay attention to the clinical presentation. Now, this condition here, very, very characteristic appearance, very special appearance. The prognosis of the case of oral squamous cell carcinoma of the floor of the mouth or of the tongue, it depends on the size of the lesion. It depends on the extension to the lymph nodes. So, yeah, but unfortunately, usually the patient, when they're presented to the clinic, it's quite late because the patient does not pay attention or does not feel the pain or the urge to go to the dentist. So they usually are presented when the case is already late. But the prognosis by just looking at the clinical picture depends on the size of the lesion and the extent of the lesion. So it needs more examination and looking at what's happening there. Yeah, so stage 4, the higher the stage, the poorer the prognosis, unfortunately. Yes, so this condition here, any suggestions for the picture that we see? All right. This is squamous papilloma. Squamous papilloma caused by human papillomavirus subtype. In fact, only 11, excuse me, because it's only caused by 11, not by 6 and 11. 6 and 11 are the causes for condyloma acuminatum. This is very confusing for some, but human papillomavirus causes many problems in the oral cavity. And it contains so many subtypes, but 11 is the cause of squamous papilloma. And as you noticed, it is a solitary lesion, which is usually the case, a single lesion, exophytic, quite white in color, because if you look under the microscope, it is very highly keratinized as a reaction to the presence of the virus. And you will definitely notice, I don't have a histological picture here, but I would expect to see coilocytes or a large number of cells that are infected with this virus. So the answer is squamous papilloma, and it is caused by human papillomavirus. Thank you very much. Okay, so identify the condition and why do you think it's significant? Okay. Any suggestions? I think we'll move on. This is erythroplakia. It's a very high risk premalignant lesion. Erythroplakia represents a more dangerous lesion compared to leukoplakia. It has features, different features of this redness is due to the thinness of the epithelium. Coverage of the area becomes very thin, the prickle cell layer quite thin, so the submucosa or the area that contains blood vessels are quite visible underneath, which reflects this red color or erythema, excuse me. So erythroplakia has a very high, usually it contains a very high level of dysplasia or changes that appear in the cells, mostly the features of pleomorphism and crowding of the cell in the basal cell layer of the epithelium, and in a lot of the cases it transforms into malignancy. So it's a highly dangerous condition. This condition should be very easy to identify. Okay, any takers? This is basal cell carcinoma. Look at the pearly appearance that we talked about. The lesion looks like a small pearl. You have these rolled borders. You have these small blood vessels running through the surface of the lesion, very fine telangiectasia. And you have some bleeding in this area or some maybe keratinization that became dark in color. So this is a clinical presentation of basal cell carcinoma.